festivities of the afternoon. And again, first of all, I want to thank you on behalf of the Illinois Cancer Care Foundation for coming out and joining us this afternoon. We're pleased to be here and offer some cancer-related information to you. And so pleased that you're able to come. My name is Janet Barnes, and I'm the director of the foundation. And we were able to put this program on today due to a generous grant we received a few years ago from the Amgen pharmaceutical company. And part of that grant was to disseminate information about the importance of clinical cancer trials and try to disseminate that information throughout central and western Illinois. And so this is part of that effort, and again, to bring other speakers to you to talk about cancer-related issues. So this is an opportunity for you to learn and to ask questions and share with us. And I know that Dr. and Nancy will be available to answer questions through the remainder of the program, so take advantage of having them here. I'd like to thank also Tammy is here. Probably most of you know Tammy. So if you have any questions of her, don't hesitate to ask. And then Jason Harlow from our pharmacy is here. So any med questions, feel free to twist his arm. Just for those of you that don't know anything about our foundation, we did put in your packets at your tables just an informational brochure about us. But our foundation is really dedicated to funding initiatives, patient initiatives involving research, education and awareness, and then patient assistance. Again, the preponderance of our monies go to support the shortfall between what we receive from the National Cancer Institute to operate our clinical trials program and what it actually costs to provide the care to those trial patients. And last year that was about $350,000. So that's kind of our major focus, is supporting research and being able to bring cutting-edge treatments to our patients in Central Illinois so that they can stay home for their care and not have to travel, have any other type of hardships. Again, we talked a little bit about educational programs like this, and then we go to a number of health fairs and different types of venues where patients or individuals will be and disseminate information. So we're always willing, if you have any kinds of groups that you belong to, organizations, and you're looking for a speaker, just let us know. We'd be happy to arrange to come over and talk to your group. And then again, we also, and you're going to learn more about this today with Nancy here, but we're funding some initiatives in genetic screening. We've got two specific to hereditary cancers in both breast and colorectal. And our funding really supports patients and their family members who are eligible for these tests and either don't have insurance or have some other type of financial barrier to be able to have this testing. And so that's where our dollars come in, to be able to pay for testing for patients, their family members, so that again, they can know their risks and be able to be free of uncertainty about whether they're carrying a mutation, and allow them to make informed decisions about their health care. And then another program similar to this is in genetic tumor sequencing, which I'll let the expert back here talk a little bit more about it in her presentation as it relates to genetics. But again, there are certain types of cancers that respond very positively to certain compounds that are out there, and based on whatever their genetic markers are, if the patient is eligible for that particular compound or drug, we're able to go to the pharmaceutical or biotech company and say, we'd like to bring that treatment to Peoria, Macomb, wherever the patient may be, and we're able to bring a treatment here that otherwise the patients would not have access to locally. One of the other things we do in terms of patient assistance, we have a Trust and Hope program whereby we have a cadre of volunteers that go out during the holiday times. At Thanksgiving, we deliver Thanksgiving meals to patients in need throughout Central Illinois. our volunteers will go wherever. I assume they come over here to Macomb. Lauren would know. Yeah. So we support patients in your community as well. And then we do the same thing at Christmas time. We help families of terminally ill patients by doing all their Christmas shopping for the kids for them. So we get lists from the families. We have volunteers that go out with foundation funding and buy the gifts for the children. And we allow those families to see those gifts, wrap those gifts, but it's just one less thing they have to worry about at the holiday time. We just take care of all that for them. Just a couple things before I introduce Nancy. You have a couple little cards at your tables. This card is an about card. If you would be so kind, before you leave this afternoon, if you would complete this form, it really helps us plan events like this and gives us important feedback. So if you would take a few minutes and complete that, we would greatly appreciate that. And then this card too is for, as you are listening to Nancy, if you have any questions, if you would write down your questions, and then when she's done with kind of her formal remarks, Lauren or Leslie will come around and we'll collect these questions, and then she and Dr. Meter will answer your questions for you. So those are kind of the formalities. And so I'd like to introduce Nancy Donini. She is an oncology certified registered nurse, and she's been with Illinois Cancer Care for the past 9 years. As our genetics nurse coordinator, she works really closely with our oncologists and hematologists, and she helps genetics patients understand and manage their risks for developing cancer. She is very passionate in her work with cancer patients and is tireless in piecing together their genetic puzzle to help them determine the best course of treatment. She's a graduate of the intensive course in cancer research assessment presented by the City of Hope Division of Clinical Cancer Genetics in Duarte, California. She was actually able to participate with folks from all across the world. It's an elite 4-month program that she and Dr. Nose participated in, and it's really viewed as the premier source of comprehensive practice-focused cancer genetics training in the world. So we're really excited to have her part of our team and your team. And so with that, I will let Nancy take it off and talk to you a little bit about genetics.
Thank you, Tina. Okay, we're a small enough group, so we're going to be informal. Before I start my talk, I'm going to take it from the most expensive part of this whole thing, which is the genetic test, to the cheapest, easiest thing out there, and I bet you everyone in this room would have a hard time with it. How many of you guys, if I asked you right now, tell me about your family history, could do that? Tell me about your mom, your dad, your brothers, your sisters, your aunts, your uncles, your cousins, your grandparents. You could? Yes? That's good. I have one. Anybody else know all about your family history? That's great. That is the cheapest, easiest tool out there to get the ball rolling on where we're going to talk about today. And you would be surprised how many people don't know anything about their family history, or they know very little, or they know that their grandma died of something that made her be in bed for days and days and days, but they can't tell you that she had cancer or that she had ovarian cancer. So hopefully as I just go through this, you'll see where that basic information about your family is really the key to genetics in general. So we'll just start with that. Everybody wonders, like, who should be screened or who should have genetic testing? Well, for starters, 37% of all breast cancer cases should be tested. They should be screened and tested. 100% of people with ovarian cancer should be tested. If you have a history of ovarian cancer, you should come see us. 24% of all people with colorectal cancer should be tested. So, of all the cancers out there that we know about, 5 to 10% of them can be attributed to a hereditary cancer syndrome. And so that's our goal, is to identify those people, and identifying if you're a person who's had cancer, and we can identify the fact that you are a carrier of a hereditary cancer syndrome, we can also start to identify your at-risk relatives, because if you inherited a gene mutation then all your blood relatives, especially your first degree blood relatives, have a 50-50 chance of having the exact same thing. So if you're an oncology patient, this also can help you benefit by allowing you to receive personalized, both short-term and long-term care. So by short-term care, a newly diagnosed breast cancer patient has some decisions to make. And some of them are, do I get a lumpectomy? Do I have a mastectomy? Do I have a double mastectomy? Or do I get radiation? You have surgical decisions to make. If you fit guidelines based on your family history and the age you were when you were diagnosed, and sometimes the very type of breast cancer, you need genetic testing to help you make those decisions, because if you have, for instance, a BRCA mutation, then already we know you should probably have a bilateral mastectomy. There's lots and lots of evidence out there that shows that's the best way to approach that. If you have an ATM mutation or something called Lynch Syndrome, you should probably have a bilateral mastectomy because you shouldn't have radiation. If you have a syndrome called Lynch, radiation could cause you to end up getting something, a sarcoma. So again, genetic testing helps determine for short term your course of treatment. Long term, again, you could use a BRCA mutation carrier. So you have breast cancer and you're making decisions about surgery for breast cancer, but if you have a BRCA mutation, you're also at risk for ovarian cancer. So long term, what are we going to do about that? We'll go on to Lynch Syndrome, which is hereditary non-polyposis colorectal cancer. If we find that you have Lynch Syndrome, say maybe you're a female and you presented with colorectal cancer. Well, you're also at risk for endometrial cancer, so we need to think about, especially if we knew that up front, should you have a hysterectomy when you're going for surgery? Or later, should we monitor you in a different way because you're at risk for other cancers based on the genetic mutation we found? And with Lynch syndrome, there's 4 different genes that we know of that are kind of in the constellation of Lynch syndrome. And depending on which one of those genes is mutated, your surveillance is going to be tailored to the actual gene. You have different risks for whichever one of the genes in Lynch syndrome has the mutation. So again, back to that family history. So when you come to see us, we try to get the most thorough family history we can out of you, and we put that together in something called a pedigree. And this is the most important piece of information a genetics professional can have when they're talking to you. Because anybody with any kind of training in genetics can look at this at a glance and say, I hope somebody checked that family for BRCA, because that's definitely a BRCA family. So you can look at successive generations with breast, prostate, and ovarian cancer, younger ages, somebody with both breast and ovarian. That is just a hallmark sign that this family is probably harboring a BRCA mutation. So when we put this together, we can also go to a genetic testing company and the insurance company and say, there's good reason to test this person. And again, that's because we got a good family history. This is the Lynch family. It's missing Jen. Okay, well I have it on the Lynch family, but it's gone. Your family history is the key to identifying both the individuals at risk for the primary and secondary cancers and to identify the individuals most likely to benefit from genetic counseling or testing. So when you go see your oncologist for the first time, you're newly diagnosed with some kind of cancer, there's a lot to talk about. What kind of cancer do I have? What do I do? Do I have surgery? Do I have treatment? If I'm going to have treatment, what kind of treatment? It's an overwhelming first visit. So a lot of times, the family history doesn't get discussed as well as it could on the first visit, and it's not really the oncologist's fault. There's just so much to cover. And then you're so concerned about what do I do right now that you're not thinking about, well, my grandmother had this and my mother had this. And so if the oncologist doesn't get from you that this is running in your family, that's not the way they're going to go. So they're going to start your treatment based on what's going on right now, and not necessarily on whether this could be hereditary. But if it is hereditary, I'll give you an example. We had a patient the other day, a new breast cancer patient. We sent off the test to see if she had a BRCA mutation, but she needed to start chemo urgently. And the doctor said, I'm going to add this one drug into the mix, which it was a common regimen, but if she doesn't have a BRCA mutation, I'm going to take it out because she's not going to respond to the drug unless she has the BRCA mutation. So he's tailoring the treatment to the genetics of the person. And that's what you want. Why do you want to get a drug that's going to make you sick or make your hair fall out if you're not going to benefit from it? But then again, if you need that drug and there's good reason for it, from what we found, in your genetic testing, then obviously that's a win. You're going to benefit from this drug. So how are we doing identifying people who, the family members, the at-risk family members? Because another plus for finding people with genetic mutations is finding their family members before they get cancer. So if we find in a family they harbor a certain genetic mutation, we want to test all their blood relatives for that exact same thing, because especially in Lynch syndrome, the hereditary colon cancer, if you have colon cancer and we test you and we find that you have Lynch syndrome, if we test your brothers and sisters or your children and we find that they have it too, we can develop a screening system for them that will prevent them from getting colon cancer, because we know in colon cancer, if you take those polyps out before they transform into cancer, you can prevent cancer, or we can screen them differently and keep them healthy. So that's another win, is to keep your family healthy. So when we see people, what flags us to think that we need to test you or we need genetic counseling? For hereditary breast and ovarian cancer, if you come to us and you're under the age of 50 and you have breast cancer, that's a red flag. We're already going to be thinking, we need to look at this family. If you have something called triple negative breast cancer, meaning you don't have estrogen receptor positive, progesterone receptor positive, or overexpress the protein HER2, that's a red flag, especially if you're under 60. If you have a personal history of ovarian cancer, if there's somebody in your family, a male with breast cancer, if you have two different breast cancers, it could be in the same breast or it could be in opposite breast, but if they're two totally different cancers, that's a red flag. And if you're Jewish, I don't know if anybody, it seems like in this area there's just not as many Jewish people, but Jewish people in and of themselves have different risks. They have 3 specific mutations. They're called founder mutations. So if you tell the doctor you're Jewish, the doctor's already going to be thinking of a different way to manage your care and different way to think about whether this could be hereditary. Lynch syndrome is a little muddy sometimes, because depending on the gene, they always want to say that you should have this cancer before the age of 50, but if you have a PMS2 mutation, which is one of the Lynch genes, you very well could get colon cancer well over the age of 60. But still, you'd want to know that because you could prevent it. They can do tests on the tumor, and I'll kind of touch on that at the end of this talk because Janet kind of brought it up, but when you have colon surgery, anybody that has surgery, one of the things they do is pathology on the tumor, and they want to know what is it. So that's one of the things they do. They decide it's colon cancer. Well, while they're doing that, they can do a simple stain on 4 different slides, and they can get a tip-off right then and there of whether this might be Lynch syndrome. So if you have microsatellite instability or something called mismatch repair, and that's what they can do just by testing the tumor, that's a red flag that you might have Lynch syndrome. Somebody that has both colon and uterine cancer or colon and ovarian cancer, that's very unusual. They should be tested for Lynch syndrome. Janet, my clock is missing.
What's missing? Go to the next one.
Is this the one I turned in and you kind of tweaked it? All right, well, I already know what I'm going to say. Okay. So one of the things we talk about in genetics is risk. And we actually have models where we can plug in information you give us, and we can come up with numbers. And in breast cancer, if we come up with a certain number, we can qualify you for testing right then and there. Or if you have a family history of breast cancer, but we don't find a genetic mutation in you, we can use your family history to come up with numbers, and those numbers qualify you for MRIs instead of mammograms, or a transvaginal ultrasound to monitor for ovarian cancer. So again, we need that family history so we can take good care of you. And then, like I said, when you first go see the oncologist and you're overwhelmed by your diagnosis and you have so much to think about, you know, how is he going to treat this, and what's my prognosis, and what exactly do I have, and what stage is it? But you don't think about telling the doctor about your family history. And then Thanksgiving rolls around and you have a big family get together and everybody knows that you're being treated for breast cancer. It's out there. She found it. It's okay. I knew my Lynch Syndrome slide was missing.
Uh-oh.
So you get more information at Thanksgiving. You found out that your grandma, who somebody said died of consumption, actually died of ovarian cancer. Or you find out that your Aunt Sally never told anybody she had breast cancer because it was kind of a stigma back then to have cancer. So now you have more information. Well, now you've also built a relationship with your oncologist. You see that doctor on a regular basis. You've developed a trust relationship. So actually, he's asking or she's asking how you're doing. You say, you know, at Thanksgiving, we had this big get-together, and I found out that my grandmother had ovarian cancer and my mother's sister actually died of breast cancer. Well, the oncologist is going to think, oh, this changes things. You know, this is changing your risk. So we just thought you had breast cancer before, but now you might have a hereditary form of breast cancer based on this history you're giving us. So let's look at your ovaries. Or let's refer you on to genetics and have somebody take a look at this history and see if you should be tested. So do you see how, you know, if you tell the doctor on your first visit, no, I don't think anybody in my family has cancer, you know, or, oh, well, somebody died of cancer, but just one person. They're just going to look at you and they're going to treat you. But if you come back months or even years later and you have more history to add, that's going to change your risk. That's going to change how we approach, how we think that we should approach your care. So what can you do? Well, you can learn as much about your family history as possible. That is probably the single most important thing all of us can do in managing our health, is learn about our family history. Because a lot of things that happen, and it's not just cancer, there's heart conditions, diabetes. A lot of it is affected by our lifestyle, but a lot of it is pre-programmed into us through our genes. So it's good to know what goes on in your family, because if you know your risk, you can start a plan to manage that risk. And then definitely share the information with your oncologist or your primary care physician, because if they don't know your family history, they cannot put that piece of the puzzle together. And then update your family history whenever you learn about new information about your family, and share that with your oncologist. And then if you fall into certain guidelines, and there again, you know, most of the doctors in our practice are well aware of when they should refer somebody on to genetics. If your disease or your particular stage, or when you got the disease, your age at presentation, or your family history all comes together to fit a certain picture, then the oncologist is going to refer you on for genetic counseling and testing. In our practice, you'll meet with Dr. Nost. He's an oncologist also. He specializes in genetics, and he'll go over your case and he'll explain why you should or shouldn't be tested, and then we'll get that ordered for you. And then you'll come back and talk to him again and go over the results. And if we find a genetic mutation in you, then your responsibility is to share that with your family, because you can help your family not get cancer by giving them this information. If there is a genetic mutation in your family, everyone in your family should be tested for it, And then if they have it, we should help them come up with a plan to stay healthy. That's the whole idea. And then I'll just touch a little bit about, there's another aspect to genetics that's coming to the forefront, and that's when Janet was talking about testing your tumor. There's, I think you're going to be hearing about this more and more over the next year even. There's a very simple test that a molecular testing company can do on your tumor, and they can actually look at the tumor and see what mutations are in the tumor. Now that's separate from all the mutations that you could have inherited, because the tumor itself changes over time. Sometimes it changes to outsmart chemotherapy. Sometimes it changes as it grows. But those mutations in the tumor that we can test for now can actually be matched up to drugs to help treat that particular type of cancer. So look for that in the coming months and years, that you're going to hear more and more about sequencing your tumor to look for driver mutations and match that up to drugs that will work for you. And that's all I have.
Thank you, Nancy. Do we have, go ahead.
Would you comment on the fact that if a mutation is found, we as the doctors and staff cannot tell family members that it really has to be
Yes.
from the family? There's been real great debate about this, because all of a sudden we're not letting people know that they're at risk, but we are not allowed to share that information.
Yeah, HIPAA still rules, and it is your personal information. So if you go see Dr. Veeder and he tells you you have a BRCA mutation, he's going to advise you to share that with your family. And we had this happen the other day. A lady came to us with newfound breast cancer, and when her relative found out she had breast cancer, she said, "Oh, I never told you I was tested and I have a BRCA mutation." Think about that. If that person would have been told that 4 or 5 years ago, she could have been tested for it, and then she could have made some decisions or choices that could have prevented her from coming to us that day. And it's not to say that you have to have a mastectomy because you have a BRCA mutation, but you could qualify for every 6-month MRIs. You could try taking a drug called tamoxifen, or if you're postmenopausal, a drug called aromasin to try to prevent it. We're going to find it at a much earlier stage so that we can cure it with surgery. So you're not being fair to your family members if you don't share that. It's almost criminal, really, if you think about it. I mean, it's fine to be private about your health care, but if you have something that affects not just you, but other members of your family, you really owe it to them to share.
Yep. I had a question. You were talking about the family history. Is it best, first degree relative is always important to know, but what about the second degree and third degree relatives?
Good
and what's
question.
the difference?
Here's an
between them?
example. A BRCA is a good example. A man can carry a BRCA mutation, and if he has BRCA2, he's at increased risk for prostate cancer. Some BRCA1s, but mostly BRCA2. So say you have a BRCA1 mutation in your family, you might not know it, because if there's a lot of men and they're the carriers, it might go 3 or 4 generations before you have this female show up with breast cancer, and you might look at that family and think, where did this come from? Well, one of the things we do too when we look at those pedigrees is it a limited family history? Is there a lot of males, and then all of a sudden a female shows up with breast cancer? We might be able to get that person tested just based on the fact that there's not a good family history and there's a lot of males. But yes, or what might happen in that case is, so you have like a 48-year-old female with breast cancer. Dad is fine as far as we know, but then you go up another generation, but dad's mom had ovarian cancer. So dad's probably the carrier, but he just didn't get cancer yet because his risks are a little different. So yes, it matters. First degree, of course, but I think clear up into third degree, you should try.
And my other question is, have you noticed an increase with Vietnam veterans with Agent Orange and their children as far as cancers?
I think they've linked hairy cell leukemia to Agent Orange. You know, that I just had to write a paper about something on that order, and there's birth defects happening to children whose parents and grandparents were exposed to Agent Orange. So that would be not necessarily, that is genetic in a way, but it's a different
Okay.
avenue. But yes, that's happening.
But that's important for people to know if they
Yes.
were in the
Yes,
fields. And
yeah. I think that we've only, there's a lot more to Agent Orange than a sad time in our country's history.
What other questions? Anybody have cards they'd rather be anonymous? Anybody want to be anonymous with your questions with a card?
Well, I have a question.
Sure.
I've had non-Hodgkin's and breast cancer, and my sister is concerned about her chances of getting cancer. We had a mother who had colon cancer, we had my dad's mother who had breast cancer, and my mother's sister had breast cancer. Now, is this something that
Well,
I should discuss with my doctor
Mhm.
and see?
but what was first? Did you have non-Hodgkin?
Non-Hodgkin's.
And then, did you get radiation?
I had chemo
Chemo,
for
okay.
non-Hodgkin's.
And then how many years later did you get breast cancer?
About 12 to 18 months.
Oh, well, there's a relationship. There is a relationship. So how old were you when you got breast cancer?
Well, let's see, it was in 2010, so I was 48.
You were under 50. And your relatives, age range for breast?
My dad's mother was in her late 40s, and my aunt, my mom's sister, was in her 70s.
So you have to also look at both sides of the family, because you're talking about two different areas of risk.
Right.
You want all the relatives to be on one side, so to speak. So if you're thinking about risk, you just have you and your dad's mother.
Right, okay.
So if you had really good insurance, we might be able to look into that. It just depends. They all have different policies, but you were under 50 and so was your relative. So we could, there again, that's where we want to see your whole family history. We wanted the whole pedigree so we can see how big is your family, were there a lot of men. You know, that's where that pedigree just comes in. It's amazing that the cheapest piece of information is your family history, and we can just tell so much by that. So, you know, the other thing is, it's not a bad idea to come to the genetics clinic to talk to Dr. Nost. You don't have to be tested. He can still go over your risk. He can still give you a general idea of what your risk is, and then he can give you ideas for how to manage going forward. So even if we don't test you, that doesn't mean you don't have risk. You know, you obviously have some risk.
Well, until my grandmother, I was the only one.
Yep.
I haven't had a cousin, an aunt, a first degree of nothing that's ever had cancer.
Yeah.
So,
Those are the tough cases, but it's still not a bad idea to sit down and have that conversation, go over that history, and talk about it. And then it depends, like, was your breast cancer triple negative? Do you know that?
I don't remember.
Yeah, see, that matters too. So if you were triple negative and you were you're triple negative under 60, right there is a reason to be tested. So, see, it's really not a bad idea just to sit down and have that conversation. Not everybody has to be tested.
What other questions? Any other questions?
I have neuroendocrine pancreatic cancer. Should I have my daughter checked? I know it's a real rare cancer.
Yeah. Do you have much of a history of pancreatic in general?
Not that I am aware of any kind.
Prostate among men?
No.
No.
Had, both my father and my uncle had lung cancer, but that was because they smoked like stovepipes.
I would say no.
Well, that's what, Mike and I talked about it, but I just was curious.
And then that neuroendocrine component makes
Yeah,
it a
it
little
makes
bit
it so
different
crazy,
too.
so.
Yeah. There again, we want to see that family history. We want to see what's.
Well, I don't know of one even clear back into like the 1800s that I know of.
Really? You're a good group. I cannot tell you how many people say, I don't know anything about my dad's side of the family. What is it about dads? It's frustrating, but it's terrible. People come in all the time and say, I don't know anything about my dad's side. And that's half your DNA right there. You need to learn learn about your dad's side of the family. Somehow, find an aunt, find somebody, but get that information. It's important for your children, too. It's really a legacy to leave your kids a nice family history. It really is. Yeah.
So I'm gonna have a colonoscopy sometime soon. Is there any way I can, they're not gonna do any of this testing routinely, right?
Well,
But,
they'd have to find something on your colonoscopy and you don't want them to.
right, but let's say they do. They still wouldn't be routinely genetically testing this stuff unless
If they
I,
found a tumor,
unless I did it in advance, had it arranged in
not
advance.
yet, but someday, I think someday that will just be a part of the workup, will be what's driving that tumor. But no, they wouldn't.
Even if I tried to get it going in advance. It would-
No, but here's not all, I found this out through what I've been doing. The Bloomington hospitals only save pathology specimens for 4 years. The Peoria hospitals save them for 10. You want them to save them for 10. When they take a tumor out of any of you, any of us, they put it in little paraffin blocks, little wax blocks, and it looks like a little tiny dab inside a clear wax block. And they categorize those, and they code them, and they give them a number, and it translates back to you, and they keep them in a special place for up to 10 years. And you can go back. We just did this the other day to a 10-year-old tumor, and we sequenced it, and we got tons of information. So even if they don't do it at that moment, that doesn't mean that it can't be done. They don't throw that away. If they find cancer in you, it's kind of weird, but in our world, it's a wonderful thing. They save it. And you want them to. Because when new advances come along, or just like when we test people for a germline mutation with a genetic testing company, we ask you to sign off for, can they use the sample for research? And if you say yes, and you should, they save that sample for years and years and years. And it's not you they're interested in, it's how old were you when you got breast cancer, or ovarian, or colon? What's your race? Are you male or female? And then they go back years later and get that sample back out, and they can tell all kinds of things. And they have solved so many mysteries by people allowing them to save their samples.
I have a question, a related question though. How important is it, for example, if you have polyps removed, to know what the pathology is on those polyps?
Very. A polyp is not a polyp is not a polyp. There's adenomatous polyps, there's hyperplastic polyps, there's serrated polyps, and it matters big time. And it matters how many polyps, and it matters where they found the polyps. It matters the size of the polyps, and all of those can translate into a syndrome, can translate into you needing to have your colon removed. I mean, you could write books on polyps. They're interesting little growths in your colon, but no two polyps are alike. So yes, it's very important to know what kind of polyps, how many polyps, where they found those polyps. We actually had 2 patients have their colon removed because they had so many polyps, it was only a matter of time before they were going to have colon cancer. And so many polyps that they couldn't remove them all during a colonoscopy. And some serrated polyps are flat, and they're very hard for the gastroenterologist to even see when they're doing a colonoscopy. So if you know that you have serrated polyps or flat polyps, there's chromoendoscopy that you can have instead of a colonoscopy, where they actually go up and they spray blue dye in the colon before they do the colonoscopy, and it actually separates out those polyps so that they can see them and count them and get their size. So there's a lot more to our colons than we realize. Good question.
Dr. Veeder, anything you want to add or discuss?
Very well done, and I think just the amount of we're learning every year we're out of date every year. And so I've noticed sometimes when I've covered genetic issues, I thought with a patient, I'm seeing them every 6 months, and I look back and say, oh geez, well we obviously covered it, but now there's 4 more pieces of information that really opens up whole new doors again that we didn't think we had enough information to test before or need to, and now we do. So I think all of us have to keep thinking about the new information we have. And we're probably much more predetermined than we ever want to think, but there's an awful lot in the genetics that's coming out. And I assume that everybody will have a genome test.
Yes, that's
With
next,
the cancer. I mean,
exome testing.
we're gonna do it, and again, we get an awful lot of information now from that we don't have any idea what to do with it. I have people coming in a hematology case, like leukemia, lymphoma, there might be 5 mutations in the DNA if you do whole genome sequencing. If you've been a smoker and have lung cancer, you've got 240 different mutations in your DNA, and many of those mutations we don't have any idea what to do with yet. So it's one more example of technology leaping ahead of our knowledge of it. And again, the Genome Project 10 years ago cost $3 million to do, and probably within 2 years you're going to go down to Walmart and for $500 you can get your whole DNA sequenced. So again, it's great progress, but also great unknown. And just last month they had on radio a debate between one of the chief geneticists at University of Chicago and one at Barnes, and one was for telling a patient absolutely everything, all the mutations, share everything with him. And the other one kept saying, no, geez, we don't have enough information to know what to do with those. So even among experts, and there's both, we've worked with both those people, I've heard their names, but clearly the debate is there. So there'll be a lot more genetic information out than we know what to do with it. But as Nancy mentioned, some of those DNA changes can be affected by a drug. Somewhere in the country, somebody has a drug that they're working on just that one rare mutation, and we can get people to that center and get them treated. So it's a brave new world, good and bad, but it's certainly going to continue to escalate in the years to come.
And I don't recommend going out to any of those places where you can just get your DNA sequence, because you know what? Somebody needs to interpret that report for you. You need a genetics professional to interpret that, or you're going to get information that you don't know what to do with, so don't do that. You'll be sorry. You need somebody to sit down with you and interpret that information for you.
One of the drugstore chains was about to start that within the last year, and the FDA put the kibosh on it for that very reason, that they were going to have thousands of people running around with information that no one understood, and they don't even know who to ask. But they've beaten them back the first time, but as the price comes down and everything comes down, you just know that's where we're going to be within a few years.
Yep. There's good and bad,
Yeah.
for sure. I'll give you one more example that I think is really cool. And we actually have a case going on in our office right now, but with exome sequencing, that is when they look at just, I think it's up to 20,000 base pairs in your body. So there's a rare kind of ovarian cancer called small cell carcinoma of the ovary. And they know it's familial. They know that, these young girls get it. They're always under 30 and they don't do well. But they saw generation after generation, but they don't know what causes it. So they finally used exome sequencing, and they would take 2 or 3 family members who are affected, and they looked at all the DNA in all 3 of them, and they finally found the gene. So now we have something to test for. They don't have the test for the gene just yet, but I would say in the next couple years, there's one more thing that we can help somebody not get that horrible disease. So there's a lot of promising things coming with genetics.
Thank you, Nancy.
Yeah.